Right. Well, I'll start. It's Mariette here. Good day, everyone. Bonjour and buenos dias, because I think there is someone from Colombia, I think, living in Brazil. So I thought I'd just greet everyone. So Marni and I are very pleased to present our work today on early childhood development and how early childhood services and programs and how they can address health equities over the life course. I'd like to begin with a traditional territories acknowledgement. We're from the University of Manitoba, and we acknowledge that the campuses are located on the original lands of Anishinaabe, Cree, Ojibwe, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. I just wanted to present a few, Marni and I thought we should talk a little bit about the background and some very good work that was done on early childhood development and some of the evidence that talks about early childhood as a crucial development period. This report was from 2012. It was written by, and edited rather, by Michel Boivin and Clyde Hertzman. But we thought we'd bring your attention to it today just because it's a very good piece of work that's still relevant today that talks about the life course epidemiology, developmental neuroscience. It talks about epigenetics, the role of genetics and environmental factors, and then dedicates some writing to prevention science. And so it really brings home the point that we need to do everything in our power to prevent adversity in childhood. I mean, there'll always be some, but if we can reduce the adversity in childhood, it will increase the chances of good lifelong health. They also, though, point out at the end of their report, and I think this was partly the impetus for us to really dedicate our work to this, is that while there is some evidence to back prevention and early intervention programs, the evaluation and research in this area is lacking. And so we have I guess I have a research program that Marni will talk about in a minute that set out to do exactly that. Another report that we based ourselves on is the Early Childhood Development, a Powerful Equalizer. And what that report talked about was, again, the critical foundation of early childhood development. And that's because early childhood development, including physical, social, emotional, language, and cognitive domains, strongly influence basic learning, school success, economic participation, social citizenry, and health. Both of these reports use this model or framework called a Team ECD framework. And this is a bioecological model that many of us, I think, on the call are familiar with. And so it talks about the individual child and all their characteristics that they are born with, but also the very important influences of their families, their communities, their regions, so all the levels, their country, and the global environment. They also talk about the life course approach. What I liked also is that there's the two squares there that overlap, and one of them talks about the relational community, so where the child or the individual gets their identity, so First Nations or Francophone or a newcomer to a country. And also of interest today is the important influence of early childhood development services and programs.
Mariette, it's Diane. Could you speak a little more loudly?
I will.
Great.
But I'll do even better. I'll hand it over to Marni.
Thanks, Mariette, and I always speak loud. So, Thanks very much. As Mariette has just explained, we know that early childhood is a powerful influencer throughout life. And we also know that in recognition of the importance of early childhood development, there have been a multitude of programs developed to try and improve these early outcomes and hopefully later outcomes as well. But the question is, how do we know whether these programs are working? And that is exactly the first question we asked when we began a program of research at the Manitoba Centre for Health Policy called Pathways to Health and Social Equity for Children, or as we called for short, PATHS. PATHS was funded by the Canadian Institutes of Health Research as part of their programmatic grants to tackle health and health equity, and we had additional funding as well from the Heart and Stroke Foundation. So at MCHP, one of the things we found that's key to trying to influence policy with the evidence that we as researchers produce is to involve policymakers and knowledge users right from the very start. So with PATHS, even before we wrote the proposal to get the funding, which we eventually did get, we held an all-day workshop with key high-level decision makers and community organizations from a number of different sectors in Manitoba to try and find out what they thought was important to focus on. So at that workshop, together we developed with the policymakers, with the knowledge users, together we developed a plan to move forward to evaluate a number of different programs aimed at improving outcomes for kids and their families in Manitoba. And the questions we asked, listed there on the slide, is not only were we interested to find out whether or not these programs were working to improve overall health and well-being, but we also wanted to know whether the gaps or the socioeconomic inequities that we see in health and well-being would be reduced as a result of these programs. Because we know you can have a program that improves outcomes overall, but you can actually increase the gap rather than decreasing the gap. I should mention before, I know I've just switched slides, but one thing I forgot to mention, with the involvement of the knowledge users, it wasn't just at the beginning of this study. It continued throughout and has continued since the grant ended. The grant ended in 2017, but it's led to much spin-off research where we have continued to involve policymakers, knowledge users in producing and disseminating research at MCHP. So how do we go about doing this research? Well, the foundation for our research is a very large repository of data we have at MCHP. This particular figure shows you some of the key databases, but there are over 80 different data sets housed in the repository. And that includes administrative data sets, things like physician claims and hospital discharge abstracts, but there's also survey data and clinical data, program data like we used in PATHS, and registry data. And many of these data sets are for the whole population, so they cover everybody in Manitoba. We never have any names or addresses or other personal identifiers in these data, but there is a scrambled numeric identifier that allows us to link across the databases and over time, which provides a really powerful resource for research, and that's exactly what we used for PATHS. The data, if you just look along the bottom of this slide, the data are available across the life course from the prenatal period right throughout adulthood, so really from pre-cradle to grave. But in PATHS, we focused on programs for kids, so it was from prenatal till adolescence. And today, I've circled the two programs that were really focused on early childhood development and improving early childhood development, and that's the Healthy Baby program, which I'm going to talk about briefly, and then Mariette's we're going to give it back to Mariette to talk about the Family's First Home Visiting Program. But you can see the other programs that we evaluated go right across the spectrum of childhood. So to get to the Healthy Baby program, the Healthy Baby program in Manitoba has been operating for almost a couple decades, and there's two components. The program itself is focused on improving pre- and perinatal health. And there's two components. There's the Healthy Baby Prenatal Benefit, and there are community support programs. Today I'm just going to focus on the prenatal benefit, but we do have evaluations of the community support programs. So what the prenatal benefit is exactly what it sounds like. It's an income supplement that women receive during pregnancy, during their second and third trimester, in the amount of $81.41 a month. It's actually on a sliding scale depending on your income, but the maximum amount is $81.41 a month. To be eligible for the program, you need to be pregnant, and so you need to make at least one doctor or practitioner visit to get a confirmation of that pregnancy. You need to complete the application. You have to have a net family income less than $32,000, but I should mention that almost all the families in this program have much, much lower incomes. Because of that sliding scale, I think it's about $9 a month that the families who are closer to $32,000 get. But the ones who are getting the $81.41 a month have much, much lower incomes, family incomes, and you have to be a resident of Manitoba. So, of course, we were interested in knowing whether the Healthy Baby Prenatal Benefit was associated with better outcomes, not just perinatal outcomes, but we wanted to look a little further out as well. And so we used our repository of data. We were able to look at thousands and thousands of women who had received the prenatal benefit and look at outcomes such as low birth weight, small and large for gestational age, preterm birth, we looked at 5-minute APGAR scores, length of stay for the birth hospitalization, and breastfeeding initiation. And you might be wondering, okay, why would money during pregnancy have anything to do with breastfeeding initiation? But along with that monthly check comes some information about how to have a healthy baby. And one of the things that's encouraged not only is good prenatal nutrition, but the importance of breastfeeding. We looked also further out at readmissions for neonates or hospital admissions at any time in the first 2 years of life. And we also looked at immunization rates at 1 and 2 years of age. We thought this would be a good measure of connection to health services because that is one of the goals of the Healthy Baby program. And then we even looked as far out as when kids were entering school. We looked at how they were doing across 5 developmental domains that are measured by the Early Development Instrument, or the EDI. And so here's your first polling question. I feel like I should have a drum set here, but the polling question is it possible that $81.41 a month during pregnancy has any impact on neonatal and child outcomes? We'll see the answers coming in. At least I can see them. I don't know if everybody can see that.
Mm-hmm. Yeah, we can see them.
Oh, good.
Oh, my.
So it looks like, most people think that the $81.41 a month will have an impact. To tell you the truth, when Mariette and I first started this research, and we had a whole team involved, I should acknowledge them. I'm not going to say all their names, but when we first started this research, we thought the answer would be no. I'm just trying to close this poll here. I don't know, Diane, okay, there we go. We thought the answer would be no, but actually we did find that there were some positive associations. So we found the Healthy Baby Prenatal Benefit was associated with a decrease in low birth weight births, a decrease in preterm births, a decrease in the length of birth hospitalization, the length of stay for the birth hospitalization for the baby. There was an increase in breastfeeding initiation. There was an increase in immunization at 1 and 2 years of age for the kids whose moms had received this prenatal benefit. And even at the kindergarten entry, the kids whose moms had received this benefit during pregnancy had better language and cognitive scores on the Early Development Instrument. And that's the domain that is really the best predictor of future school success. So, as I said near the beginning, we for each of the programs that we evaluated as part of PATHS, we asked not only whether the program was working, but we also asked whether the gap was reduced as a result of the program. And so for the Healthy Baby, we looked at the 3 outcomes that we found were the most robust in terms of improvements, and that was breastfeeding initiation, low birth weight births, and preterm births. And we compared all the low-income women in Manitoba who were eligible for the Healthy Baby prenatal benefit to all women who weren't eligible because they weren't receiving it, and looked at that gap between them. You know, we know breastfeeding rates are higher for women who aren't low income. We know low birth weight and preterm births are lower for women who aren't low income. But what we found was, as a result of the Healthy Baby prenatal benefit, those gaps decreased. They didn't close completely, but they did decrease as a result of receiving that really moderate amount of money during pregnancy. And I'm going to pass back over to Mariette now.
Great, thanks. All right, so the second program that we looked at is called the Families First Home Visiting Program. It began in the early 2000s in Manitoba, so it's been going on for quite a while. It is a targeted program for families with multiple challenges, such as poverty, being a single parent, having problems with their mental health, relationship problems. And the aim is to enhance parents' capacity to provide a nurturing and supportive environment for their children. Manitoba at any time has about 1,500 families who are receiving home visiting, which is about 10% of all births in Manitoba. Essentially, the families are visited by a trained paraprofessional or non-professional home visitor. And sometimes, depending on the family's needs, sometimes it's just once a month or every 2 weeks. The families are offered the program for up to 3 years, so the average time is about half of that, about 18 months. And they do follow a curriculum which is focused on parenting, child development, and family functioning. So that describes the program, and this is what we wanted to evaluate to see if the Families First Home Visiting was associated with positive outcomes for children. I just wanted to put this in. PowerPoint, but all the results that I'll show today are in these articles. So do children in the home visiting program have better outcomes? And the outcomes that we examined were being taken into care before the child's first birthday, their second birthday, and their third birthday. And this is based on the Child and Family Services database that was linked to program data. We also looked at hospitalizations for child maltreatment-related injuries. There are ICD codes that suggest that the injuries are related to child maltreatment, so this is what we used as a definition. We looked at immunization rates at 1 year and at 2 years of age. And we also looked at, in the education data, child development scores at kindergarten, so based on the early development instruments. And what we found was that children who had been exposed to the home visiting program compared to those who had not been, and all of them were families with parenting challenges, they were less likely to be taken into care at their first, second, and third birthday. The odds ratios ranged from 0.75 to 0.80, which is, about a 20 to 25% decrease in rates of being taken into care. Hospitalizations for child maltreatment, this was associated with the home visiting program. The children in the home visiting program had half the rates of hospitalization for child maltreatment-related injuries. There were higher rates of immunization among those in the home visiting program, 6% higher at 1 year and 10% higher at 2 years. However, we found no differences in child development scores at kindergarten. Those in the program were up in arms. They were saying, what? That's not possible. But we checked several times and found that both groups, those in the program and those not in the program, had essentially the same scores. So I have a following question for you. At a population level, we just saw that there were some differences between families in the program and families not in the program. But we wondered, at a population level, does the Families First Home Visiting Program reduce the gap? And I'm wondering if we could see what people on this webinar think. And that again, we really wondered, and we also wondered how do you even measure this? And what we're seeing is that there are some differing hypotheses out there, but the majority of you seem to think that at a population level, the Family First Home Visiting does reduce the gap. And maybe I'll just maybe we didn't need to do this study. Everyone on the webinar already knew that it in fact did reduce the gap. So let me show you. I'm not sure how to get back to my slides. Aha, thank you. So we looked at those the outcome being taken into care by first birthday. And so what we did is we looked at families who would have met the criteria to be in the program but did not receive the program, and their rates of their children being taken into care was 10%, very high. And we compared it to families who were not at risk, and their rate was 2.3%. Then we looked at, so then we compared that to those who were in the Families First program. And what we noted was that those in the Families First program, their rate was 7.4%, so that in fact the gap had been reduced. We also looked at immunizations. So immunizations at 1 year. Those who were not in the Families First program.
Mariette, it's
yes.
Diane. Could you please speak more loudly? We're still having trouble hearing you.
Oh, I'm so sorry. I think I'm looking at my screen, and that's the problem. So I will talk.
Okay, thanks. Thank you.
So those families who would have, had many challenges, parenting challenges, and had not received the Families First program, their immunizations at year 1, their rate was 78.2%. 78.2% of children had been immunized, had their full immunizations by their first year. Those were not at risk. Those at risk were 72.5%. So there was a gap there. When we looked at those in Families First, we found that those families were 78.0%. So the gap was very negligible between those who were at risk but had received home visiting services and everyone else in Manitoba, all other kids in Manitoba who were not at risk. So that tells us a little bit about how early childhood programs can have an impact on outcomes over the life course. I just wanted to bring your attention to this model or framework from the Center on the Developing Child at Harvard University. What we see on the left-hand side is many policies and programs that are levers for change, really. And so, we talked about some public health programs here, but there's, also child welfare programs, different early interventions that can then have an impact on parents and caregivers' capacity and community capacity through more time and commitment, skill and knowledge development, financial, psychological, and institutional resources, which in turn has an impact on creating an environment, a stable, responsive environment for the child. And then we see that this in turn has an impact on lifelong well-being. So we really like this model. In conclusion, unconditional prenatal income supplement is associated with better maternal and child outcomes, as Marni showed us. And that placing conditions on income supplements may not be necessary. Home visiting was associated with higher immunizations and lower child maltreatment rates. But we also found that the program did not improve child development scores at kindergarten. So there is the opportunity to enhance the program to improve child development scores at school entry. And so these studies suggest that ECD programs can reduce population-level health and social inequities. So we would just like to acknowledge our team. Marni, do you want to say something about this slide? Oh, she's muted.
But I had to unmute. I had to remember how to do that. Yeah, just, PAS Equity for Kids, our PAS program involved a lot of researchers across a number of disciplines, as well as policymakers, so just acknowledging all their input to the very small pieces of research that or results that Mariette and I were able to present here today.
That's great. Thank you, Marni and Mariette. The questions are flying in, and people are obviously really, really interested in the results and the fact that there's been some impact proven. And I remember early on, Marni, you and I were having a chat about this, and I've known about this research for a while, and we were saying, there needs to be a way to kind of get it out to the rest of the country, because there's probably a lot of people that don't know about it and the proven results. And so that's really obvious